Welcome to the deep dive. Today we're embarking on an immersive exploration into the intricate world of pharmacology.
That's right.
Our goal isn't just to skim the surface or, understand a few isolated facts. It's about truly mastering the foundational concepts that elite professionals in this field rely on every single day.
Absolutely. The bedrock principles.
Exactly. We're talking about how drugs interact with our bodies, how they're meticulously developed, how they're continuously monitored for safety and effectiveness, and how all of this really profound knowledge is applied in real-world life-saving situations.
It's a big field.
It is. This is a comprehensive journey, really designed to transform your understanding.
And our mission for you is precise. We're here to extract the most critical nuggets of knowledge from a rich stack of sources, turning what might seem like incredibly complex information into clear, actionable insights.
Making it usable.
Exactly. This deep dive is custom-tailored for you to become truly well-informed, ready to understand the nuances of this absolutely essential field, and approach it with the depth and clarity that professionals use. So, let's get started. The foundational pillars of pharmacology. What is this science all about?
Okay, let's unpack this. Pharmacology. It sounds like a big, intimidating word, something you'd maybe encounter in a high-level science class. But what does it truly encompass? What is pharmacology at its core, and why is it so vital?
Well, at its heart, pharmacology is the science of how drugs interact with living organisms and, well, complex biological systems.
Oh, yeah.
Think of it as the comprehensive study of medicines, not just what they are, but how they produce their effects, where they act, how the body handles them, and critically, how to use them safely and effectively for medicinal purposes.
So it bridges a few fields.
It really does. It's the bridge between chemistry, biology, and medicine. And when we talk about a drug, the World Health Organization, the WHO, gives us a very broad and useful definition.
What's that?
It's any substance or product that is used or intended to be used to modify or explore physiological systems or pathological states for the benefit of the recipient.
It's pretty broad then.
Very broad. Whether it's a simple over-the-counter pain reliever or, a cutting-edge cancer therapeutic, understanding its pharmacology is essential.
That's a really clear starting point. So if pharmacology is this broad science, how do we even begin to understand how a specific drug works once it's introduced into the body? I mean, it gets absorbed, it travels, it does something, and then it eventually leaves, right? That sounds like a whole intricate journey for every single pill or injection.
You've perfectly captured the essence of the two fundamental branches we use to study drug characteristics, and they indeed describe that entire journey. They are pharmacokinetics and pharmacodynamics.
Right.
Imagine a drug as maybe a tiny adventurer setting off into the vast landscape of your body.
Okay, I like that analogy.
So pharmacokinetics describes the journey of the drug through the body, essentially, what the body does to the drug.
What the body does to the drug.
Okay. This breaks down into 4 critical stages, often remembered by the acronym ADME.
ADME. Got it.
A is for absorption, how the drug gets from its administration site, like your stomach or maybe a muscle injection, into the bloodstream. It's about how quickly and how efficiently it enters circulation.
Makes sense.
D is distribution. Once it's in the blood, where does the drug go? Does it reach the brain, the liver, muscles, or does it stay largely within the blood? This depends on things like blood flow, how well it binds to tissues, and barriers like the blood-brain barrier.
Okay.
M is metabolism. This is how the body chemically transforms the drug, usually in the liver, often making it easier to excrete. Sometimes metabolism can actually activate a drug or maybe even create toxic byproducts.
So it changes the drug.
It changes it, yes. And finally, E is excretion, how the drug or its metabolites leaves the body, typically through the kidneys and urine, but also possibly via bile, feces, or even your breath. Understanding ADME tells us crucial things. The time of onset for a drug's effect, how long it will last its duration of action, and ultimately how the body handles the drug from entry to exit. It's all about the drug's path and fate inside you.
Right, the journey. So what's the other part? Pharmacodynamics.
Exactly. Then we have pharmacodynamics, which describes the journey of the drug's effects on the body, essentially, what the drug does to the body.
Okay, so the flip side.
The flip side, this is where the magic, or sometimes the challenge, happens. Here, we're focused on its effects on various target sites. These are specific molecular components in your cells. The drug interacts with like receptors, enzymes, ion channels.
The drug's destination.
Precisely. And also its precise mechanism of action. This explains how the drug interacts with these targets to produce a biological response. Does it block something, activate something, interfere with a pathogen.
Got it. So pharmacokinetics is the delivery system. Pharmacodynamics is what it does when it gets there.
You've got it. Together, they give us that holistic picture of drug action.
It truly sounds like a whole language in itself, with specialized terms for everything. To really master this, what are some of the other key terms we'll encounter as we go deeper? And what's the crucial insight each one provides?
You're absolutely right. It's a precise vocabulary, and understanding these terms is foundational.
Okay.
So first, pharmacotherapeutics. This isn't just theory, it's the practical application of all our drug knowledge. It's about making real-world, patient-specific decisions, drug selection, dosage, duration for diagnosis, prevention, treatment. The core insight. Optimizing patient outcomes, choosing the right therapy for the disease and severity.
The doing part of pharmacology.
Exactly. Then, clinical pharmacology. This is where the rubber meets the road, the study of drugs in humans. Vital for new drug development, studying everything from how a drug behaves in people, those pharmacokinetic and pharmacodynamic profiles, to adverse effects. The key insight. It bridges basic science and patient care, making sure drugs are used safely and effectively in clinics. Pharmacoepidemiology. Now we step back from the individual. This field studies drug interactions, uses, side effects across defined populations. The insight it offers is huge for public health. It helps us understand and optimize drug use at a broader societal level, spotting trends or widespread issues.
Seeing the bigger picture.
Precisely. Pharmacogenomics. This is a really exciting, rapidly evolving field. It explores how your unique genetic makeup influences your response to drugs. The transformative insight here. The potential for truly individualized therapy, customizing drug choice, dosage based on your personal genetic blueprint to maximize effectiveness and minimize side effects.
Wow, personalized medicine.
It really is. Then there's pharmacoeconomics. This is about the value of health interventions. It rigorously evaluates the costs and effects of pharmaceutical products and services. It's core insight, helping us make rational decisions about resource allocation, comparing drugs based on financial burden versus health benefits. We use tools like cost minimization, cost benefit, cost effectiveness, cost utility analyses.
The money side of medicine.
It's crucial, pharmacovigilance. This embodies the ongoing commitment to drug safety after a drug is approved. The WHO defines it as a science that involves activities related to detection, assessment, understanding, and prevention of adverse effects or any other medicine or vaccine-related problem. The critical insight. Drug safety is continuous, lifelong. Constant monitoring is needed to protect public health.
The safety net, essentially.
A vital one, chemotherapy. Often misunderstood as just for cancer, its broader definition is the use of drugs with selective toxicity, meaning the drug preferentially harms invaders, bacteria, viruses, cancer cells with minimal damage to host tissues. The insight is the deliberate design exploiting biochemical differences.
Targeting the impact.
Exactly. Clinical pharmacy. This describes the direct patient care role of clinical pharmacists. They apply their deep knowledge to ensure optimal, safe, rational drug use for individual patients. The insight? Pharmacists are active, frontline members of the healthcare team, optimizing complex drug regimens.
Makes sense.
Pharmacopoeia. This is a cornerstone of drug quality, an officially published book with standardized info on medicine identification, quality specs, directions for use. The insight, it's a legal and scientific standard, ensuring consistency, quality, reliability.
Like a rule book for drugs.
A very important one. And finally, essential medicines, a concept pioneered by WHO back in 1977. It defines medicines satisfying priority healthcare needs that should always be available in adequate amounts, appropriate forms, and affordably. The profound insight. Global commitment to health equity, ensuring critical drugs are universally accessible. These terms are really the building blocks. 2. The blueprint for better care. Evidence-based medicine and therapeutic drug monitoring.
Okay, once we understand the language and these foundational concepts, how do we make sure we're making the best medical decisions? Moving beyond just intuition or experience to something more rigorous, that's where evidence-based medicine, EBM, comes in, right? It's not just what a doctor thinks works, but what the science shows.
Precisely. Evidence-based medicine, EBM, is fundamentally about integrating the best available scientific evidence from medical literature with clinical expertise and patient values to guide patient care decisions.
So it's a three-legged stool, almost.
That's a great way to put it. The idea isn't brand new. Its roots go back to the mid-19th century. It reflects a long drive for data-driven healthcare. The core process involves systematically finding relevant information, critically appraising its validity and applicability to your specific situation, and then diligently applying it. EBM is a powerful blend. It combines the doctor's skills and experience with a commitment to quality care, maintaining patient dignity, and crucially, it integrates systematic research. The benefits: improved medical outcomes, reduced harmful effects by identifying risky interventions, enhanced cost effectiveness, and it promotes informed, shared decision-making, always keeping your preferences central.
How do you find that best available evidence?
We rely on rigorous, systematic literature searches using specialized search engines, like the TRACH database, turning research into practice. Then, the info is analyzed using advanced techniques like meta-analysis and systematic reviews, which pool findings from multiple studies to give the strongest evidence. It really transforms clinical practice into a data-informed science.
So once treatment starts, based on that evidence, how do we fine-tune it for you, the individual? Because people respond differently, and dosages need to be precise, especially for certain drugs, right? I'm thinking about therapeutic drug monitoring here, TDM. It sounds like the ultimate in personalized medicine.
You're absolutely right. Therapeutic drug monitoring, or TDM, is indeed a vital tool for individualizing treatment. It involves precisely measuring the concentration of a drug in your serum, or sometimes other fluids, and then using that data to meticulously adjust your dosage.
Why is that so important?
Its primary purpose is to maximize the drug's effectiveness while ensuring its safety. And a significant side benefit: it can improve pharmacoeconomics by reducing complications and hospital stays.
Okay, so how is it done? What do you measure?
Well, the assays vary. We might measure the total drug concentration, or sometimes just the free drug concentration, that's the active part. Sometimes measuring active metabolites is key too. We usually use blood, plasma, or serum, but sometimes urine, sputum, even tears, depending on the drug.
And when do you take the sample? Does timing matter?
Timing is absolutely critical. For dose adjustment, we typically take the sample just before the next dose, that's called a trough level, once the drug has reached a steady state. This tells us if the average level is right. But if we suspect toxicity, we take the sample as soon as possible.
Got it. And how do you use that number to change the dose?
We use the measured steady-state plasma concentration, CPSS, to calculate a new dose. There's a simple ratio. Measured CS divided by desired CIBS equals the previous dose divided by the new dose. So you can calculate the new dose rate needed. It allows for very precise, patient-specific adjustments.
So when is TDM absolutely crucial? And when is it maybe not needed?
Good question. TDM is indispensable when the plasma concentration strongly correlates with the therapeutic or toxic effect, like for certain antibiotics, aminoglycosides, for example, where too low fails, too high causes damage, or for antiepileptics, where levels are key to seizure control. It's also vital when you can't easily assess the drug's effect directly. Think antipsychotics or antimaniacs. Behavioral changes can be slow or subjective. Levels give an objective measure, and critically for drugs with a low therapeutic index.
Meaning a narrow safety margin.
Exactly. A narrow window between effective and toxic. Think antiarrhythmics, digoxin, lithium. Small variations matter hugely. It's also used for drugs like phenytoin to suppress isolated events like seizures, and of course for diagnosing and managing overdoses or poisonings, especially with an unclear history.
Okay, so when is it not needed?
Generally, TDM isn't required when plasma concentration doesn't reliably correlate with the effect, or when the drug's effects are easily measured by other means like blood pressure, glucose, or INR for anticoagulants. Also for drugs with uncomplicated pharmacokinetics or a wide safety margin like paracetamol. And usually not for drugs with very long action, irreversible effects like aspirin, or hit-and-run drugs like omeprazole, where the effect lasts longer than the drug in the plasma.
Can you give some examples of drugs where TDM is common?
Sure. We routinely monitor aminoglycosides like gentamicin, theophylline, methotrexate, phenytoin, digoxin, lidocaine, lithium, tricyclic antidepressants, and cyclosporin. For these, TDM is really a cornerstone of safe prescribing.
So summarizing TDM, it's about individualizing therapy, maximizing effect, minimizing toxicity, managing poisoning, checking compliance, adjusting for organ dysfunction, and avoiding interactions.
You've nailed it. It's precision medicine in action. 3. The journey of the pill. Drug formulations and delivery systems.
We've talked about what drugs are, how they work, how we monitor them.
Yeah.
But how does that powerful molecule actually get into your body? It's not always just swallowing a pill. That's the world of drug formulations, isn't it? Sounds like a mix of science and maybe a bit of art.
It absolutely is both. Drug formulations are the meticulously prepared forms containing the active drug plus various inert ingredients, excipients.
Excipients.
Yeah, things like vehicles, preservatives, flavoring agents. They're all designed to dispense the drug in a suitable dosage form for administration, the goal.
Yeah?
Get the drug to its target effectively and safely. We usually administer drugs via 3 broad routes:
Hmm.
enteral, via the gut, like oral meds, parenteral by injection, and topical, local application.
So what are the different forms a drug can take? Beyond a simple pill, there must be a huge variety, right? Each designed for a specific need.
Indeed. Dosage forms can be solid, semi-solid, or liquid. Let's start with solid dosage forms, probably the most common. Tablets. Compressed solid forms. You have simple, uncoated ones. Film-coated tablets have a thin polymer layer, makes them easier to swallow, masks taste, protects the drug. And enteric-coated tablets are clever.
How so?
They resist stomach acid and dissolve only in the small intestine, crucial for drugs that irritate the stomach or get destroyed by acid. Then you have controlled release tablets, sustained release, extended release. They release the drug slowly over time.
So fewer doses needed.
Exactly. More consistent effect, better adherence, fewer peaks and troughs. You also have lozenges dissolving slowly in the mouth for local effects or absorption there. Powders. Finely divided drugs, some for internal use like ORS, others external like antifungal powders. Because they're fine, they often dissolve faster than tablets, maybe quicker action, simpler compound. Capsules. Drug enclosed in a gelatin shell. Hard gelatin for powders, soft gelatin often for oils. And then spancels, a type of controlled release capsule with granules releasing slowly over hours. Longer action, steady levels.
Okay, what about semi-solids?
Semi-solid preparations are mainly topical. Ointments, creams, gels, pastes. Different consistencies, different absorption.
And liquids? Seems like a lot there.
Very diverse. For internal use, syrups, solutions, linctus for cough, elixirs, tinctures, solutions for injection, sterile. Mixtures need shaking, emulsions, drops. Also liquids for rectal use like enemas. For external use, liniments rubbed in, lotions, and tinctures like povidone iodine antiseptic. Each form is carefully chosen.
Beyond these standard forms, there are some really ingenious ways drugs are delivered now, aren't there? Science finding new ways to get the drug exactly where needed, right amount, right duration.
Absolutely. The innovation is remarkable. We have special dosage forms like aerosols for inhalation. Think salbutamol via a metered dose inhaler for asthma, direct to lungs, less systemic effect, then depot injections.
Like a long-lasting shot.
Exactly. Drug release slowly over a long time from the injection site, like testosterone depot injections lasting weeks or months. Other special forms: suppositories, rectal, pessaries, vaginal, bougies, urethral. For local effects or systemic absorption, bypassing the liver first pass, and the transdermal adhesive patch.
The skin patch, right?
Right. Drug delivered through the skin, multi-layered, backing film, reservoir, micropore membrane, adhesive layer, often a priming dose. Think nitroglycerin for angina, scopolamine for motion sickness, convenient, sustained delivery.
And then there are even more specialized systems.
Yes, specialized drug delivery systems designed for highly targeted, controlled delivery. The advantages are compelling: reduced side effects, controlled release, drug protection from degradation, improved therapeutic profile, reduced toxicity. Safer, more effective treatments.
Like what kind of systems?
Well, consider the liposomal drug delivery system. Tiny phospholipid spheres encapsulating the drug, releasing it when the wall breaks down. Amphotericin B, an antifungal, is much less toxic to kidneys in a liposome. Or ocuserts for eye drug delivery. Sterile inserts with drug in polymers sandwiched between membranes. Controlled release right into the eye. Better contact time, longer action, less drainage than drops. Placed in the lower conjunctival sac.
Clever.
Progestacerts. Intrauterine devices with progesterone, releasing constantly for contraception, maybe up to a year. Computerized miniature pumps, programmable for continuous or intermittent release. Think insulin pumps or GnRH pumps mimicking natural pulses. And cutting edge. Monoclonal antibodies as drug carriers.
Targeted delivery.
Highly targeted. Antibodies designed using hybridoma tech to react with specific antigens, like on cancer cells, delivers the drug right there, minimizing systemic harm. It's aiming for the ultimate in precision.
4V, the watchful eye. Pharmacovigilance and adverse drug reaction, ADR reporting. Okay, even with the best science, careful formulations, precise delivery, drugs can still have unexpected effects out in the real world. That's where pharmacovigilance steps in, right? It's like an ongoing safety check. Catching what trials might miss.
Exactly. The importance of post-marketing surveillance, a key part of pharmacovigilance, cannot be overstated. Clinical trials, while thorough, use relatively small selected populations for a limited time. Many ADRs, especially rare ones, long-term effects, or drug interactions, are actually detected after a drug is on the market, used by a much larger, diverse population.
So continuous monitoring is vital.
Absolutely. Historically, manufacturers submitted periodic safety updates for 4 years. But recognizing the need for a more systematic global approach, the WHO established guidelines for pharmacovigilance centers worldwide. The data from these national centers flows to the WHO Uppsala Monitoring Center, UMC, in Sweden.
A global hub.
Yes, the global hub for drug safety info. It allows detection of signals, potential new ADRs from data aggregated across countries. And to really understand the WHO definition of pharmacovigilance, it's a science that involves activities related to detection, assessment, understanding, and prevention of adverse effects or any other medicine or vaccine-related problem. It's not a one-off. It's continuous dynamic monitoring over the entire life cycle.
Why is that continuity so important?
It's crucial for educating prescribers and the public, reducing drug-related harms, and promoting rational, safe, effective drug use. It's proactive safety.
So who are the key players in this safety network? Must be a lot of different people and organizations involved.
It absolutely is. Pharmacovigilance involves a wide array of stakeholders. Manufacturers, fundamentally responsible. Prescribing doctors and healthcare workers, often the first to spot ADRs. Research organizations, clinical pharmacologists with specialized expertise. And regulatory authorities overseeing the whole system.
How do they gather the information?
Through various post-marketing surveillance methods. Voluntary reporting by healthcare professionals is critical, capturing real-world data. Prescription event monitoring (PEM) systematically tracks all events in large patient cohorts. And pharmacoepidemiologic studies, like cohort or case control studies, rigorously investigate safety in populations. The collected ADR data is analyzed, and crucial safety info is spread through drug alerts, newsletters, advisories.
Let's bring this closer to home. How does pharmacovigilance work in a country like India? What's the structure there?
In India, the Pharmacovigilance Program of India, PVPI, was launched in 2010. It operates through two key bodies: the Central Drugs Standard Control Organization, CDSCO, the regulator, and the Indian Pharmacopoeia Commission, IPC, which acts as the National Coordination Center, NCC, the hub for data collection and analysis.
And who oversees it?
The National Pharmacovigilance Advisory Committee provides guidance. The program has a multi-tiered network of peripheral, regional, and zonal centers across the country for widespread data collection. The PVPI objectives are clear and ambitious. Monitor ADRs, including interactions, detect reactions causing hospitalization, death, disability in India, educate healthcare professionals about ADRs, involve all stakeholders, and establish a national center meeting global standards.
So where does the reporting actually happen?
At the ADR monitoring centers, AMCs, set up in medical colleges and healthcare facilities. When an ADR is tested, it's reported using a standardized suspected adverse reaction reporting form. At the AMC, causality, did the drug cause it? And severity are assessed using scales like WHO or Naranjo's.
That assessment is key for quality.
Absolutely. Then the data, as individual case safety reporting forms, goes to the NCC PVPI via an online system called Vigiflow. A final causality assessment happens there, and a report goes to the National Pharmacovigilance Database. Crucially, this anonymized data is also uploaded to the UMC ADR database, Vigibase, in Sweden.
Contributing to the global picture.
Precisely. This allows India's data to help detect global safety trends. When a possible causal link between an event and a drug emerges from multiple reports, that's a signal. It triggers further investigation, maybe leading to regulatory action or updated prescribing info via emergency interventions. When volume and pressure matter.
Okay, let's shift gears now to emergencies. Situations where immediate, precise action is absolutely life-saving. We often hear about plasma expanders being used. What exactly are they, and why are they so critical when, minutes, even seconds count?
Right. In critical emergencies, especially involving significant fluid loss, plasma expanders are high molecular weight agents. When infused intravenously, they rapidly increase plasma volume.
How do they do that?
By pulling fluid from the surrounding tissues, the interstitial space, into the bloodstream. They do this by raising the colloidal osmotic pressure inside the blood vessels.
Okay. So when are they most needed?
In cases of severe hypovolemia, think hemorrhagic shock from bleeding or extensive fluid loss from severe burns. Ideally, you'd use whole blood or plasma for replacement, but those aren't always immediately available in an emergency.
So the expanders are a bridge.
Exactly. Synthetic plasma expanders provide a rapid, immediate solution to boost blood volume and stabilize the patient until definitive treatment, like blood transfusion, can be given. An ideal plasma expander needs several key characteristics. It should be inert, not reacting undesirably. It must exert high osmotic pressure to draw fluid effectively. It needs a long shelf life. It must be non-antigenic, minimizing allergic reactions, and of course, suitable for safe IV infusion.
So what are the different types? You mentioned synthetic ones. How do they differ, especially in these critical emergency roles?
Right, there are different types. Broadly, crystalloids and colloids. Crystalloids like normal saline or Ringer solution are used, but they diffuse quickly out of the blood vessels. For more sustained expansion, we focus on colloids.
Because they have bigger molecules.
Exactly. Bigger molecules that stay in the bloodstream longer, giving a more prolonged osmotic effect. Let's look at the main colloids. Human albumin solution, HAS, is often seen as a gold standard. It's 96% albumin from human blood, heat sterilized, big advantage in emergencies. No clotting factors or blood group antibodies, so no blood typing needed beforehand.
How effective is it?
Very. 100 millibellas of 25% HAS can increase blood volume by around 450 millibellas, depending on the patient. But like any blood product, there's a risk of hypersensitivity.
Okay, what else?
Dextrans. These are polysaccharides from sugar beet, two main types. Dextran 40, faster, shorter acting, and Dextran 70, more common, longer acting. They're cost-effective, long shelf life, but limitations.
Gotcha.
They can interfere with blood grouping and cross-matching, they can affect coagulation, and they can cause anaphylactoid reactions, itching, low blood pressure. A major concern is potential acute renal impairment if used in large amounts.
Right.
Gelatins. Polypeptides from bovine collagen,
Yeah.
similar osmotic pressure to albumin, non-antigenic, preservative-free, good shelf life. Importantly, they generally don't affect renal function as much as dextrans, used sometimes for priming heart-lung or dialysis machines.
Okay, any others?
Hydroxyethyl starch, het test starch, a natural polymer. A 6% solution can improve hemodynamics for up to 24 hours. It might also decrease capillary leakage and improve microcirculation. But it, too, can affect coagulation. Side effects can include vomiting, chills, flu-like symptoms, anaphylactoid reactions. And finally, hypertonic saline. It rapidly pulls extravascular fluid into circulation for a brief plasma expansion, often given with a colloid like HES or dextran to prolong its action. It's like an initial rapid volume booster.
So where are these expanders typically indicated?
Primarily to improve blood or plasma volume rapidly in critical states, severe hemorrhage, hypovolemic shock, endotoxic shock. Human albumin specifically in severe burns, acute hypoproteinemia, or acute liver failure. Dextrans and gelatins also as priming fluids for machines.
And these expanders are often used in shock. That's a critical state. How do we define shock and its different forms? That distinction must be crucial for treatment, right?
Absolutely. Shock is a severe acute circulatory failure. The core problem is decreased tissue perfusion, leading to inadequate oxygen delivery and use by cells. This causes organ dysfunction. It's initially reversible, but progresses rapidly if untreated.
Does it always mean low blood pressure?
Often, but not always. Patients can be normotensive or even hypertensive initially. It's a complex state with many causes, and understanding the cause is key. We classify shock broadly into 4 types based on the underlying cause: hypovolemic, distributive, cardiogenic, and obstructive.
Okay, break those down.
Hypovolemic shock. Due to sudden loss of plasma or blood volume. Hemorrhage, burns, severe dehydration from vomiting, diarrhea. Not enough volume circulating. Distributive shock. Characterized by severe peripheral vasodilation, blood vessels relax widely, dropping pressure despite enough volume. The most common type is septic shock, from a dysregulated immune response to infection. Bacterial toxins trigger mediators causing vasodilation, leaky capillaries, organ failure. Common culprits: gram-positives, resistant bugs; gram-negatives, fungi, other causes. SIRS, like in pancreatitis; anaphylactic shock, severe allergy, histamine release; toxins, neurogenic causes like spinal injury; cardiogenic shock, the heart pump itself fails; caused by MI, sustained fast heart rhythms, VT, severe valve problems; obstructive shock, pump failure due to something outside the heart blocking flow, often poor right ventricular outwind. Examples: tension pneumothorax, collapsed lung compressing heart, large pulmonary embolus, clot in lung artery; severe pulmonary hypertension, valve obstruction, venous air embolus. Differentiating these is critical for choosing the right treatment.
Given how critical shock is, what are the general principles for managing it? How do we intervene to save a life? What's the sequence?
Shock is a true medical emergency. Management focuses on correcting hemodynamics to maintain blood pressure and restore organ perfusion. The approach is systematic and fast. The initial, often most crucial step, fluid resuscitation. Volume replacement is the mainstay. The choice of fluid depends on the cause we use. Colloids, albumin, heat of starch, dextrans, which stay in the vessels longer, crystalloids, saline, Ringer's lactate for initial rapid expansion, and blood products, packed RBCs, plasma, platelets, if needed for blood loss or clotting issues.
Non-fluid.
The specific fluid and rate depend on the volume deficit, the patient's condition, and any electrolyte or acid-base problems. The goal is to rapidly restore circulating volume to optimize what we call cardiac preload.
Okay, once volume is addressed, what if that's not enough? How do you support the heart and blood pressure directly? That's where the powerful drugs come in, right? Vasopressors, inotropes.
Exactly. If fluids alone don't restore pressure and perfusion, we turn to inotropic agents and vasopressors, usually via continuous IV infusion. These directly affect heart contractility and blood vessel term. Norepinephrine, Levophed, often a first-line choice. Increases blood pressure mainly via alpha-1 stimulation, vasoconstriction, increased resistance. Also has some beta-1 effects stimulating the heart. Dose is usually 0.1 up to maybe 3.5 micrograms constriction. Caution. Intense vasoconstriction can sometimes reduce organ blood flow, can cause reflex bradycardia, and tissue necrosis if it leaks out of the vein, needs central access ideally. Dopamine. Dose-dependent effects. Low dose, 2 to 5 milliseculagemin, increases renal blood flow, D1 effect. Moderate dose, 5-10 milliseculagemin corrects, increases cardiac output, beta-1 effect. High dose, 10 milliseculagemin. Alpha-1 effect dominates vasoconstriction, often preferred in cardiogenic shock due to the renal blood flow effect. Also needs large vein infusion. Side effects. Tachycardia, atrial fibrillation, epinephrine, adrenaline, stimulates both alpha and beta receptors, increases heart rate, stroke volume, BP. Drug of choice in anaphylactic shock due to bronchodilation and vasoconstriction, dose 5-15 mg for cardiac support. Effective, but side effects can limit use in other shock types compared to norepinephrine. Dobutamine, a synthetic inodilator, positive inotropic, stronger heartbeat, plus vasodilator, selective beta-1 agonist, increases cardiac output, stroke volume. Given AV 2 to 5 milliseculagemin for decompensated heart failure and shock, especially septic shock with myocardial depression, often with norepinephrine. Caution, can cause significant tachycardia, harmful in coronary artery disease.
Are there other vasopressors used?
Yes, adjunctive vasopressors. Vasopressin, antidiuretic hormone, causes vasoconstriction via V1 receptors. Used in septic shock, often with norepinephrine dopamine, to reach target blood pressure or reduce other drug doses, catecholamine sparing. Given 5e at low doses, 0.01, 0.04 units min, also increases water reabsorption, B2 effect. Terlipressin, synthetic vasopressin analog, more selective V1 agonist, fewer side effects, longer duration. Single 5e dose, 1 to 2 milligrams, raises BP for hours.
What else is crucial in managing shock, especially septic shock?
Absolutely critical in septic shock. Get blood cultures before starting broad-spectrum antibiotics. This allows tailoring therapy later. Also, corticosteroids, like IV hydrocortisone up to 300 milligrams per day, are sometimes considered for patients responding poorly to fluids and vasopressors. They have anti-inflammatory effects and enhance the effect of catecholamines. It's a multi-pronged approach. 6. Crisis in the heart. Managing myocardial infarction.
From broad circulatory failure, let's zero in on a specific devastating event. A heart attack or myocardial infarction? MI. We all know the term, but to truly master this, what exactly is happening in the body during an MI? What makes it such a critical emergency?
Right. An MI is an acute, life-threatening condition where blood flow in a coronary artery is severely reduced or totally blocked. Usually this happens because of underlying atherosclerosis plaque buildup narrows the artery, and then a blood clot, a thrombus, forms and blocks it completely.
So the heart muscle doesn't get bled.
Exactly. When blood flow is cut off for too long, the heart muscle cell, myocardial cells, suffer from severe lack of blood, ischemia, and lack of oxygen, hypoxia. This leads to irreversible damage and cell death. The critical point. Every minute counts. The longer the blockage, the more heart muscle dies, directly impacting future heart function and survival. It's truly a race against time to restore blood flow.
So when someone is having an MI, what are the immediate overarching goals? Time is clearly of the essence.
Absolutely critical. The immediate goals are multifaceted, focusing on damage control, symptom relief, and restoring that blood flow. First, maintain oxygenation, reduce further damage from hypoxia, improve efficiency of remaining heart function. Second, reduce further thrombosis and occlusion, stop the clot growing, prevent new clots forming. Third, reduce pain and anxiety. Severe pain and anxiety increase heart workload. Managing these helps the patient and reduces stress on the heart. Fourth, reduce cardiac workload. Lessen the demand on the struggling heart muscle by controlling heart rate and blood pressure. These 4 targets guide everything we do immediately.
And how do we achieve those targets in those critical moments? What's the step-by-step approach?
It's a highly structured rapid response, sometimes called monomorphine, oxygen, nitroglycerin, aspirin, though the order can vary. 1. Airway, breathing, circulation, ABC. Assess and maintain these first. Oxygen therapy, if saturation 90% or patient is breathless. Establish 4V access immediately for drugs. 2. Antiplatelet drugs, cornerstone. Aspirin given immediately, usually 162 325 milligrams chewable, non-enteric coated for rapid absorption. It inhibits thromboxane A2, stopping platelets clumping. If allergic to aspirin or needing more effect, clopidogrel, oral P2Y12 inhibitor, for example, 75 milligrams is given. 3. Treatment of pain and anxiety. Glyceryl trinitrate, GTN, sublingually every 3 to 5 mins if stable. It vasodilates, reducing cardiac workload and pain. If GTN fails after 3 doses, morphine parenterally. Powerful pain relief, reduces apprehension, cuts catecholamine release, helps breathing, reduces preload, lowers oxygen demand. Diazepam might be used for anxiety too. 4. Thrombolytic therapy, fibrinolysis or PCI. This is the crucial reperfusion step. Thrombolytic drugs, plasminogen activators, break down the clot, fibrinolysis, reducing infarct size, restoring blood flow. Must be started ASAP, mortality reduced if within 6-12 hours. Examples: alteplase, retiplase, tenecteplase, fibrin specific. Streptokinase is older, non-specific, cheaper, but can cause reactions. However, the preferred method if timely and available. Primary percutaneous coronary intervention, PCI, angioplasty and stenting, more direct, often more effective, especially early on. 5. Anticoagulants, to prevent clot extension recurrence. Unfractionated or low molecular weight heparin initially, then oral anticoagulants. 6. Nitroglycerin. Intravenous nitroglycerin decreases cardiac workload, improves blood flow, and can reduce mortality when given a D.
That's a comprehensive immediate response. But what about ongoing treatment after stabilization? How do you ensure the best long-term outcome and prevent future MIs?
Right. After the immediate crisis, several adjunctive treatments are crucial for long-term benefits and secondary prevention. Often continued for years, sometimes life. Beta blockers like metoprolol, atenolol, often started 4V early if no contraindications. Vital. They reduce infarct size, lower arrhythmia risk, decrease cardiac work, reduce mortality, then continued orally long-term. Angiotensin-converting enzyme, ACE inhibitors, given orally long-term, especially with reduced heart function. Huge survival benefit. They prevent adverse cardiac remodeling, the heart changing shape after an MI, and prevent or slow heart failure. HMG-CoA enzyme inhibitors, statins. Essential long-term, started in almost all MI patients regardless of cholesterol. Beyond lipid lowering, they have pleiotropic effects, reducing inflammation, stabilizing plaques, antithrombotic effects, highly beneficial. Antiplatelet drugs, secondary prevention. Continuing antiplatelet therapy is critical. Long-term aspirin, often combined with P2Y12 inhibitor, clopidogrel, prasugrel, ticagrelor, for a specific duration based on risk. This comprehensive regimen optimizes recovery and improves survival. 7. Clearing the airways, drugs used in cough.
Okay, from life-threatening conditions to something incredibly common, a cough. We all get them. Most of us just grab a syrup. But there's clearly more to managing a cough than that, isn't there? It's common, but can be complex.
You're absolutely right. A cough is more than just an annoyance. It's a crucial, involuntary protective reflex. Its job is to defend the respiratory tract, keep airways open, and remove excess secretions or irritants.
And when we talk about coughing stuff up,
That's expectoration or sputum production, coughing up and spitting out respiratory material, like mucus or phlegm. Clinically, we categorize coughs by duration. Acute is less than 3 weeks, often viral. Subacute is 3 to 8 weeks, and chronic is over 8 weeks, often indicating something more persistent.
what usually causes coughs?
Lots of things. Acute viral URIs, bronchitis, acute or chronic, sinus issues, allergies, pertussis, COPD flare-ups, asthma, GERD, acid reflux, even some drugs like ACE inhibitors.
So how do we approach managing a cough? Is it always about stopping it, or does it depend on the type of cough?
It absolutely depends. The key distinction is non-productive, dry, irritating, versus productive, wet with sputum. For non-productive coughs, the goal is suppression. That's where antitussives come in. They're classified based on where they act, centrally and peripherally, or peripherally.
Okay, let's break those down.
1. Centrally acting antitussives. These work directly on the cough center in the brainstem, medulla. Codeine, a well-known opioid, suppresses cough via mu receptors, works at lower doses than needed for pain relief, 10-20 milligrams 2-3 times day, Lord day. Side effects: nausea, constipation, drowsiness, but low addiction risk at these doses. Noscapine, another opioid alkaloid, potent antitussive, but importantly, no other opioid effects like analgesia, drowsiness, or abuse potential. Safer in that regard. Fulcodine, synthetic opioid derivative, more potent than codeine, longer lasting. Also no abuse potential, less constipation, drowsiness. Dextromethorphan, synthetic opioid derivative, very common over the counter, similar potency to codeine, but generally fewer side effects, often found in combination products.
Okay, what about the dual-acting ones?
2. Centrally and peripherally acting antitussives. Benzonatate, Structurally, like a local anesthetic, tetracaine, it inhibits cough receptors in the lungs and suppresses the cough center in the brain. Oral dose, 100, 200 milligram 3 times a day. Side effects, drowsiness, nausea, headache.
And purely peripheral.
3. Peripherally acting antitussives. Prenoxidazine relieves bronchospasm by inhibiting stretch receptors in the airways, considered a safer option. Demulcents. Simple things like licorice honey. They act indirectly, increasing saliva, coating the throat, soothing irritation, good for dry, tickly coughs. Local anesthetics. Sprays or lozenges. Lignocaine, bupivacaine, numb the throat lining, reduce sensitivity of receptors there.
Are there other things that help suppress cough?
Yes. Antihistamines, often in syrups, their sedative effect can help. Bronchodilators, if the cough is due to bronchospasm, asthma COPD, they open airways, help clear secretions. And steam inhalation humidifies airways, reduces irritation, helps loosen sputum.
What about productive coughs? You said we don't want to suppress those. We want to help clear them.
Exactly. For productive coughs, the goal is facilitation and clearance. That's where expectorants come in. They either increase the volume of secretions or decrease their thickness, viscosity, making them easier to cough up or clear by the cilia.
How do they work?
2 main types of action, mucokinetics and mucolytics. Mucokinetics stimulate bronchial cells to secrete more fluid, making mucus more watery. Some act indirectly by irritating the stomach, reflexively increasing respiratory secretions. Drugs include potassium iodide, ammonium chloride can cause nausea, sodium citrate, guaifenesin, very common, increases secretions and ciliary activity, guaiacol, ipecacuanha, essential oils like eucalyptus oil.
And the other type, mucolytics.
Mucolytics directly affect mucus viscosity, breaking chemical bonds within it, making it thinner. Bromhexine, derived from a plant, Adatoda vasica, depolymerizes mucopolysaccharides, releases enzymes to break down thick sputum. Side effects, increased nasalized secretions, gastric irritation, hypersensitivity. Ambroxol, a metabolite of bromhexine, similar actions. Given orally or inhaled. Acetylcysteine, very effective, breaks disulfide bonds in mucoproteins. Given orally or nebulized, 10-20% solution useful in intubated patients to liquefy secretions. Carbocysteine, similar action to acetylcysteine given orally. Caution, avoid in peptic ulcer patients as it might break down the stomach's protective mucus barrier.
So understanding the type of cough, dry or productive, is really key to choosing the right approach.
Absolutely paramount for rational therapy. 8th, guiding life, uterine relaxants and stimulants.
Let's explore an area where drug precision literally shapes life. Uterine drugs. First, uterine relaxants, also called tocolytics. What's their primary purpose in pregnancy? Seems delicate.
It is. Uterine relaxants, tocolytic agents, are primarily used to prevent or delay premature labor, typically when it occurs between 22 and 33 weeks of gestation.
Why delay it?
The critical benefit is buying precious time. Time to give the mother glucocorticoids, which cross the placenta and promote fetal lung maturation. This significantly improves the baby's chances of survival and reduces complications like respiratory distress syndrome if preterm birth happens.
That's crucial. How exactly do these drugs work to stop contractions without causing other issues?
They work in 2 main ways. First, direct action, suppressing the contraction of the myometrium, the uterine muscle, by decreasing the effect of calcium within those muscle cells. Calcium is key for muscle contraction.
Okay.
Second, indirect action, reducing the synthesis or blocking the action of natural uterine stimulants like prostaglandins or oxytocin. Inhibiting these stops the muscle contracting.
Can you give examples of specific tocolytics?
Sure, their mechanisms and issues vary. Mersey adrenergic agonists like ridodrine, isoxaprine, salbutamol, terbutaline, they relax the uterus by stimulating beta-2 receptors, reducing intracellular calcium. Ridodrine is more selective for the uterus. Given high V infusion, dose increased until contractions stop or maternal heart rate hits 120, but significant side effects.
Like what?
Cardiovascular, tachycardia, palpitations, metabolic, high blood sugar, and critically, pulmonary edema, especially if used over 48 hours, limits long use. Calcium channel blockers like nifedipine, a prominent relaxant, blocks calcium entry into myometrial cells, often given orally, e.g. 10 milligrams every 20 minutes initially, then maintenance. Advantage: oral use, fewer metabolic issues than beta agonists. Can still cause tachycardia, hypotension though. Oxytocin receptor antagonist, atosiban, a targeted alternative. Blocks oxytocin's action on its uterine receptors. Given IV bolus, then infusion up to 48 hours. Generally milder side effects. Nausea, vomiting, high blood sugar, hypotension. Magnesium sulfate, also used for preeclampsia. Acts as a tocolytic by uncoupling excitation contraction, competing with calcium. Preferred sometimes if the patient has cardiovascular or metabolic issues. Given IV infusion, UD2 4G over 15 minutes, then 1 2G. High levels risk respiratory depression, arrhythmias, increased perinatal mortality, needs careful monitoring, miscellaneous. Other things like aspirin, indomethacin, alcohol, general anesthetics, and nitrates, progesterone can relax the uterus, but aren't typically used as primary tocolytics.
Okay. And on the flip side, uterine stimulants, oxytocics, essential for childbirth and managing complications like postpartum bleeding, right?
Precisely. Uterine stimulants, oxytocic agents, are drugs that increase uterine motility and contractility, especially at term or postpartum. Crucially used for managing postpartum hemorrhage, PPH, excessive bleeding after birth, and also for inducing or augmenting labor, and sometimes for medical termination in pregnancy, abortifacients.
Let's classify these powerful agents. How do they differ?
Certainly. Three main classes: posterior pituitary hormones, ergot alkaloids, and prostaglandins. First, posterior pituitary hormones, oxytocin and desamidoxytocin. Oxytocin, a natural hormone peptide from the hypothalamus posterior pituitary, involved in milk ejection and vital for uterine contractility during labor. Pharmacologic actions: uterus. Estrogen makes the uterus much more sensitive to oxytocin late in pregnancy by increasing receptors. Slow 5e infusion causes regular, coordinated contractions, stronger, more frequent, mediated via G protein-coupled receptors. Breast contracts myoepithelial cells for milk ejection, letdown reflex. Other high doses can cause vasodilation, drop BP, reflex tachycardia. Weak antidiuretic effect: high doses with IV fluids can risk water intoxication, hyponatremia. Therapeutic uses: crucial in obstetrics, induction augmentation of labor. For postmaturity, preeclampsia, diabetes, ruptured membranes, placental issues, weak contractions. Slow 5A infusion, e.g. a 5IU and 500 ml glucose, 2.0 ml, carefully titrated. Control PPH, critical use. 5IU IM or 5E infusion right after delivery. Strong contractions compress blood vessels. Breast engorgement. Less common, intranasal spray before feeding can help milk flow. Adverse effects: powerful drug, needs caution. Incorrect use can injure mother fetus, cause uterine rupture, fetal asphyxia, death. High doses risk water intoxication, pulmonary edema, hyponatremia. Desaminoxytocin, Beckel form. Easier to give, but less consistent potent. Used for labor induction augmentation, breast engorgement.
Okay, second class, ergot alkaloids. Sounds like something from history.
They are ergot alkaloids: ergometrin, methylergonavine, dihydroergonovine, source. From the fungus Claviceps purpurea, grows on rye grains. Action: strongly, sustainedly contract the uterus, especially if relaxed postpartum. Increase force frequency. Reduce placental bed bleeding via vasoconstriction 2. Mechanism: partial agonist-antagonist at serotonin, 5-HT2, and alpha-adrenergic receptors on uterine muscle. Stimulate IP3 pathway, increase intracellular calcium, contractility. Therapeutic uses: mainly control PPH, same 0.2, 0.3 milligram IM. Also promote uterine involution, typically given after placenta delivery. Adverse effects: nausea, vomiting, increased BP. High doses due to vasoconstriction can decrease milk secretion, high doses. Contraindications, big ones: vascular disease, hypertension, angina, MI history, stroke history due to potent vasoconstriction.
Right, very important. And the third class, prostaglandins.
Yes. Prostaglandins: PGE2, dinoprostone, PGF2, 15-methyl PGF2 carboprost, misoprostol, PGE1 analog. Action: potent uterine stimulants in advanced pregnancy, also cause crucial cervical ripening, softening opening, contract both pregnant non-pregnant uterus, sensitivity increases with gestation. Increase tone amplitude, promote body contractions, relax cervix, can cause abortion earlier in pregnancy. Obstetric uses: dinoprostone, vaginal insert skull. Carboprost IM, misoprostol oral vaginal, use for labor induction, ripening PPH. Adverse effects: lower abdominal pain, nausea, vomiting, diarrhea common. Caution, critical point: do not combine with oxytocin generally. High risk of uterine rupture. Precision is absolutely key with all these agents. NICX: the war within and without. Chemotherapy and antimicrobial stewardship.
Okay, moving from the maternal realm, let's look at another critical area, fighting infections and cancer. This involves chemotherapy, which, as you mentioned, has a specific broader meaning here, right? How do these drugs wage war inside us?
That's right. Chemotherapy is broadly defined as using drugs with selective toxicity, meaning the drug is designed to preferentially harm the target, whether it's an infectious microbe, bacteria, virus, fungi, parasite, or rapidly dividing cancer cells while causing minimal damage to the host's healthy tissues.
How is that possible? Selective toxicity.
It relies on biochemical and physiological differences between the target and human cells. Maybe the bacteria has a cell wall we don't, or a unique enzyme, or a specific pathway cancer cells rely on. While commonly used for cancer, the term originally covers all antimicrobial therapy. Within this, antibiotics are specifically drugs derived from one microorganism used against another to suppress growth, bacteriostatic, or kill, bactericidal. The broader term, antimicrobial agents, includes natural antibiotics, lab-synthesized drugs, and semi-synthetic ones. We classify them by activity, antibacterial, etc., spectrum, narrow versus broad, and chemical structure, penicillins, fluoroquinolones, macrolides, etc.
But organisms, especially bacteria, they're smart. They adapt. What happens when they stop responding? That's resistance, isn't it? A huge growing problem.
It is indeed a severe and escalating global health crisis. Antimicrobial resistance happens when a microbe no longer responds to a drug that used to work. Two types. Natural resistance. The organism inherently lacks the drug's target or process. It never responded, like gram-negatives being naturally resistant to penicillin G. Acquired resistance. This is the really concerning one. An organism was sensitive, but evolved resistance over time, like Staphylococcus or Mycobacterium, TB, often driven by irrational antibiotic use, creating selective pressure for resistant strains to survive and multiply.
How do they acquire it?
Through changes in their DNA. Either random mutations or, more dangerously, transferring resistance genes, like on plasmids, from one bacterium to another. That spreads resistance fast, even across species. Let's look at the specific mechanisms of bacterial resistance. Understanding these helps us fight back. 1. Production of inactivating enzymes. Very common. Bacteria make enzymes that break down or modify the drug. Classic example, beta-lactamases, penicillinases, inactivating penicillin cephalosporins, produced by Staph aureus, N. gonorrhea, H. influenza, Pseudomonas, etc. Aminoglycosides can be inactivated by other enzymes too. 2. Alteration of the target site. The drug's target changes shape so the drug can't bind or work. Examples. Altered penicillin binding proteins, PBPs, leading to MRSA resistance. Altered DNA gyrase causing fluoroquinolone resistance. Ribosomal mutations causing macrolide resistance. 3. Cell wall membrane impermeability or increased efflux. Changes affecting drug getting in or staying in. Reduced permeability. Drug can't enter effectively. Maybe changes in the membrane or loss of entry channels. Porins. Gram-negatives losing porins can resist aminoglycosides. Increased efflux pumps. Active transporters pump the drug right back out as soon as it enters, like a bouncer kicking it out. Seen in E. coli, Pseudomonas, Salmonella, keeps internal concentration too low.
This is a truly serious global threat. So how are we tackling it systemically? That brings us to antimicrobial stewardship programs, or ASPs. Sounds crucial.
Absolutely crucial. ASPs represent a systemic approach. Antimicrobial stewardship itself means careful, responsible use of antimicrobials, ideally guided by experts. The definition is about optimal selection of drug, dosage, and duration, resulting in the best clinical outcome with minimal toxicity and lowest risk of resistance.
So ASPs are organized efforts to make that happen.
Exactly. Ongoing efforts, mainly in hospitals, but principles apply everywhere, to optimize antimicrobial use. The aims are comprehensive. Reduce inappropriate use, a key driver of resistance. Optimize drug selection, right drug, right bug. Ensure right dose duration for, maximize cure prevention, and limit unintended outcomes like resistance and ADRs.
What are the main tangible goals, beyond just less resistance?
Good question. Goals are patient-centered. First, achieve positive clinical outcomes while minimizing toxicity and resistance by avoiding misuse-overuse. Second, optimize selection, dose, duration, route, and appropriately de-escalate treatment when possible, for example, switch from broad to narrow spectrum. Third, reduce healthcare costs without compromising care quality. This is achieved via appropriate prescribing, monitoring, and educating patients and physicians.
Who's typically on an ASP team?
It's multidisciplinary. Usually an infectious disease physician, clinical microbiologist, clinical pharmacist, ID trained, infection control professional, hospital epidemiologist, and maybe an IT specialist for data support. Comprehensive expertise.
How do these programs actually work in practice? What interventions do they use day to day?
They use several key interventions. 1. Antibiotic timeout, a critical reassessment. A mandatory review of antibiotic need and choice, usually 48 to 72 hours after starting. By then, the picture is clearer, maybe culture results are back, allowing more targeted therapy, de-escalation, or stopping. 2. Pharmacy-based interventions, led by clinical pharmacists, includes dose optimization, adjusting for patient factors like kidney function, switching parenteral to oral when possible, avoiding drug interactions, avoiding duplicate therapy. 3. Interventions specific to common infections, often focus on optimizing treatment for common hospital infections like pneumonia, UTIs, skin infections. Strategies involve establishing a precise diagnosis, individualizing treatment based on cultures, actively avoiding unnecessary broad-spectrum use, and optimizing treatment duration, shortest effective course. And underpinning all this is understanding how different antibiotics work. We classify them by mechanism, inhibiting cell wall synthesis, like penicillins, inhibiting protein synthesis, tetracyclines, macrolides, altering cell membrane integrity, polymyxins, interfering with nucleic acid metabolism, fluoroquinolones, rifampicin, inhibiting folic acid synthesis, sulfonamides, causing mRNA misreading, aminoglycosides, or causing direct DNA damage, metronidazole. Knowing these mechanisms helps choose drugs and predict resistance. X, everyday dangers, food adulterants and insect repellents.
Okay, beyond direct drug use, pharmacology also helps us understand chemicals in our daily environment, things that can subtly impact health. Let's talk about food adulterants, something many of us might not even realize we're encountering. What are they, and why are they such a persistent issue?
It's a significant, often unseen public health concern. Food adulterants are substances added to food, intentionally or unintentionally. The main motive for intentional adulteration, usually economic gain.
How so?
To increase bulk, reduce quality, substitute cheaper ingredients. But these substances reduce nutritional value and, worse, make food unsafe, posing serious health risks. We distinguish two types. Intentional adulteration is deliberate for profit, mixing starch or chalk powder to increase weight, adding artificial colors to make food look better. Incidental or accidental adulteration happens unintentionally: poor storage, unhygienic handling leading to contamination with pesticides, rodent droppings, insects, or even heavy metals like lead, arsenic, mercury from water or containers.
Who regulates this in India?
Several bodies. FSSAI, Food Safety and Standards Authority of India; AGMARC, BIS, Bureau of Indian Standards. They monitor food standards. Despite this, adulterants are common in everyday items. Spices, dairy, oils, ghee, pulses, grains, sugar, rice, cereals. A real challenge for consumers.
Can you give specific examples? This is where it gets really concerning, things we eat daily.
Absolutely. Let's look at common adulterants and their harms. Coloring agents, major concern. Methanol yellow in pulses, sweets, veggies, neurotoxic, liver damage, maybe cancer. Malachite green in chili powder oils, known carcinogen. Sudan red, also used illegally, risky. Kashari dal, cheap pulse mixed with others. Chronic consumption causes neurotheorism, severe, irreversible lower limb weakness, paralysis. Milk, chalk, urea, caustic soda, starch added, can cause GI damage, kidney problems. Grains pulses, mixed with straw, sand, grit. Chronic ingestion can cause liver GI disorders. Ghee oils, butter. Ardamone oil is a common one. Causes epidemic dropsy, edema, glaucoma, heart failure. Starch is also added. Sugar, salt. Chalk powder, sand, washing soda, urea, plastic crystals, nausea, vomiting, diarrhea, allergies. Coffee powder, artificial colors, exhausted tea leaves. Liver disorders, cancers long-term. Turmeric, cumin. Lead chromate for color, arsenic, sawdust, chalk, pesticides. Liver GI disorders, cancers. Jaggery, sodium carbonate, chalk powder, nausea, vomiting, diarrhea.
Wow. So what precautions can people take?
Crucial things. Cleanse store pulses grains properly, wash fruits veg thoroughly, check seals on packaged foods, ensure FSSAI license number, expiry date, labeling are present. Being vigilant helps safeguard your health.
Okay, another area of environmental protection, insects, especially where they carry diseases. What's the science behind insect repellents we use? How do they keep bugs away?
Insect repellents are chemicals applied to skin, clothing, surfaces that deter insects, stopping them landing and biting. They don't usually kill them. Their main purpose is reducing vector-host contact, lowering rates of diseases like malaria, dengue, filaria, JE. They create a protective barrier insects avoid.
Let's explore the common types, synthetic and natural. What are the key ones? Their effectiveness, safety.
Good idea. Understanding the types helps choose right. Synthetic insect repellents. NNN, diethyl toluamide, DET. Most common, most effective globally. Lotion, cream, spray, protection 2 to 8 hours depending on concentration. 10-30% safe for adults, 10% for kids 12. Effective against mosquitoes, ticks, fleas, biting insects. Can cause skin irritation with long exposure. Extensive prolonged exposure risks rare but serious systemic effects, insomnia, mood issues, seizures, neurotoxicity. Ingestion causes GI upset. Caution. Can damage some plastic synthetics. Picaridin, a popular alternative. Odorless, less oily, good protection, 6-12 hours at 20%. Effective against mosquitoes, ticks, fleas, flies, chiggers. Mild eye irritation possible, not a skin irritant. Importantly, does not damage plastics. Perlethrin and transfluthrin, fast-acting pyrethroids, common in household mosquito vaporizer coils in India, repel up to 97% mosquitoes indoors, outdoors, also effective against flies, moths, cockroaches. Ingestion is dangerous. Nausea, vomiting, abdominal pain, ulcers, neurotoxic effects possible, headache, dizziness, convulsions, coma, need careful storage. Ethyl 3-acetyl-butyl aminopropanoate, IR 3535. Protection up to 6 hours. Against mosquitoes, ticks, lice, flies, 10-20% solution. Generally safe if ingested and inhaled accidentally, can cause eye irritation. Natural insect repellents, mainly from plant essential oils. Generally less effective, shorter acting, evaporate faster, need frequent reapplication. Citronella oil and lemon eucalyptus oil based. Prominent examples. Citronella oil, citronella seem to mask attractive scents by modulating insect odor receptors. Considered safe, can cause skin irritation at high concentrations. Safe for kids, pregnant women generally. Citriodiol from lemon eucalyptus oil. 10-20% solution gives 6 hours protection, mosquitoes, flies, gnats, also kills mites. Safe, can cause eye irritation.
So choosing involves balancing effectiveness, duration, and safety for your situation.
Exactly. Public health on a grand scale. India's national health programs.
Okay, let's zoom out from individual health to public health initiatives impacting millions. India has some truly massive national health programs. What's the big picture here? How do they fit into national policy?
India's National Health Policy, 2017, centrally aims to strengthen the government's role in boosting health systems, promotion, prevention, human resources, financial strategies for universal access. National health programs are integral to this. Each has specific goals, strategies, roadmaps for a particular health problem, aiming for affordable, acceptable, sustainable health standards for the whole population. They're proactive, long-term strategies.
Let's start with the cornerstone, immunization. Hugely cost-effective, right? What are the goals of India's efforts?
Absolutely. Universal immunization is a major goal of the NHP 2017. A multi-year strategic plan, 2017-2022, addressed regulation, security, management, R&D. India's journey began with the expanded program on immunization, 1978, renamed Universal Immunization Program, UIP, in 1985. It's one of the largest public health programs, globally uniform, high-quality vaccines, free of cost.
What are the UIP's core objectives?
Increase coverage rapidly, improve service quality, especially the cold chain for vaccine potency, monitor the program, develop self-sustaining vaccine manufacturing. The goal is universal coverage with essential vaccines. And the national immunization schedule itself is comprehensive. Let me give you the broad strokes for a deeper understanding. At birth, BCG for TB, OPV0, polio, hepatitis B, birth dose, at 6, 10, 14 weeks. Sequential doses of OPV, pentavalent, DPT, Hep B, Hib, rotavirus vaccine, RVV, fractional inactivated polio vaccine, FIPV, pneumococcal conjugate vaccine, PCV, builds immunity progressively between 9-12 months, measles and rubella, MR1, Japanese encephalitis, JE1, PCV booster, between 16-24 months, MR2, JE2 booster 1, OPV booster, reinforcing protection at 5, 6 years, 10 years, 16 years, DPT booster 2, and tetanus and adult diphtheria, TD vaccines. Continued protection for pregnant mothers, TD1, TD2, or TD booster. Protects mother and child. It's a comprehensive strategy.
Tuberculosis is still a major challenge, especially in India. What's the strategy for TB elimination? Must be multi-pronged.
It is. Following the WHO NTB strategy, India renamed its program the National Tuberculosis Elimination Program, NTP. The National Strategic Plan, NSP, 2017-2025, has 4 pillars. Detect, treat, prevent, build. These complement ongoing activities.
Okay, let's break down those pillars.
Detect. Early, accurate detection of all TB forms, drug-sensitive and resistant. Big focus on private providers, undiagnosed TB and high-risk groups. How? Scaling up free, high-sensitivity diagnostics, molecular tests, active case finding, private sector engagement, universal drug resistance testing, screening high-risk groups, vulnerability mapping. Treat, free drugs for all TB patients, rapid scaling of short regimens for resistant TB, treatment guided by drug sensitivity tests. Simplified categories, 1 for drug-sensitive cases initially. Intensive phase, 4 drugs, isoniazid, rifampicin, pyrazinamide, ethambutol for 4 months. Then continuation phase, 3 drugs, isoniazid, rifampicin, ethambutol for 4 months. Crucially, a cascade of care support systems from start to cure. Patient-friendly adherence monitoring, DOT, social support linking to welfare, nutritional support, and Dishaya Poshak Yajana. Prevent. BCG vaccination, isoniazid chemoprophylaxis, 6 months for high-risk contacts, airborne infection control, treating latent TB, contact tracing, nutritional support for malnourished, key vulnerability factor.
And build.
Build, strengthening policies, empowering institutions' human resources, improving procurement supply chain, robust surveillance structures, multi-sectoral collaboration, a truly holistic approach.
Leprosy, another disease with history and stigma. What's the current aim there?
The National Leprosy Eradication Program, NLEP, guided by the National Strategic Plan 2023-2027, aims for a leprosy-free India. Zero infection disease, zero disability, zero stigma discrimination. That dual focus is vital.
How are they trying to achieve that?
Strategies include strengthening leadership partnerships, early case detection, quality-free multi-drug therapy, preventing disease disabilities discrimination, using technology digitalization of surveillance, NICUS 2.0, and awareness campaigns like Sparch Leprosy Awareness Campaign to fight stigma directly.
Okay, moving to vector-borne diseases. Covers quite a few transmitted by insects, right?
Yes, a critical area. The National Vector-Borne Disease Control Program, NVBDCP, targets 6 major ones: malaria, lymphatic filariasis, Kala-Azar, dengue, Japanese encephalitis, chikungunya. Each needs tailored strategies.
Let's start with malaria elimination. What's the plan?
The National Framework for Malaria Elimination, 2016-2030, aims to eliminate malaria countrywide by 2030, maintain that status, and prevent reintroduction.
Wow.
Strategies include early case detection and prompt treatment, EDPT, cornerstone, testing, immediate treatment, chloroquine for PVAX, plus 14 days primaquine for radical cure. ACTs, like sulfapyrimethamine plus artesunate or artemether-lumefantrine in resistant areas, plus single primaquine dose for p-falciparum. Integrated vector management, chemical control, spraying, larvicides, fogging, biological control, personal protection, nets, repellents, community involvement, environmental management, reducing breeding sites, epidemic preparedness, partnerships, monitoring evaluation. India is categorized by annual parasite incidence, API, for tailored interventions. Remarkable progress already made.
Next, HIV/AIDS, a global challenge. What's India's approach?
The National AIDS Control Program, NAACP, launched in 1987, aims to prevent transmission, decrease morbidity, mortality, reduce socioeconomic impact. The current National Strategic Plan, 2017-2024, envisions an AIDS-free India. No new infections, no AIDS deaths, no discrimination.
What are the key strategies?
Establishing screening centers, identifying screening high-risk groups, guidelines for blood banks, education on safe sex, especially high-risk groups, changing societal norms to reduce stigma, a major barrier. Activities cover prevention, testing, counseling, treatment, free art, preventing parent-to-child transmission, PPTCT, viral load suppression, rehab, social protection. Integrated counseling and testing centers, ICTCs, are central. Collaboration with N2P for HIV/TB co-infection is key. Preventive services include targeted activities, condom promotion, blood safety, behavior change communication.
Lymphatic filariasis, filaria. Pervasive, debilitating. What's the elimination strategy?
Endemic in 16 states, affects over 600 million. The older strategy focused on vector control and case management. Current aim, eliminate filariasis entirely. Key strategy, annual mass drug administration, MDA, of antifilarial drugs, DEC plus albendazole or DEC plus ivermectin, to entire populations in endemic areas to halt transmission. Also home-based lymphedema management, hydrocell operations. Goal, 80% MDA coverage for 5-6 years to interrupt transmission.
Kala-Azar, another vector-borne issue in specific regions. How's that being tackled?
Endemic in 4 states mainly: Bihar, Jharkhand, West Bengal, UP, sporadic elsewhere. The Kala-Azar Elimination Program under NVBDCP aims to reduce mortality, reduce KA cases, reduce PKDL cases, skin-borne reservoir, prevent HIV/TB co-infection strategies. Escalated diagnosis treatment, RK39 rapid kits, oral miltefosine, transmission interruption via vector control, synthetic pyrethroid fogging for sandfly, strengthening human resources, monitoring evaluation, research guidelines, also under NVBDCP, the Program for Japanese Encephalitis, JE, control, high mortality, neurological issues, strategies, early diagnosis management, screening, integrated vector control, capacity building, specifics, early case detection, vaccination, kids 115, health education, avoiding mosquito bites, keeping pigs amplifiers away, malathion spray, and the Program for Chikungunya fever control, re-emerging virus. Strategies, early diagnosis management, surveillance, vector control, epidemic preparedness, capacity building, monitoring.
Shifting focus, water, sanitation. The National Diarrheal Disease Control Program, vital, especially for kids. Core strategy.
Launched 1983. Objective, reduce morbidity, mortality from diarrhea, reduce related malnutrition. Core strategy, zinc supplementation with oral rehydration solution, ORS. Zinc, 10 milligram tablets to 6 months old. 20 milligrams 6 months old, both for 2 weeks. Reduces severity, duration, prevents future episodes. Plus preventive interventions. Safe water, hand hygiene, food safety, sanitation, rotavirus vaccination.
Nutrition, huge public health area in India. What's being done for anemia and other nutritional disorders?
Foundational. The Poshana National Nutrition Mission aims to reduce undernutrition, enhance nutritional status, kids, pregnant lactating women. Multi-ministerial integrate schemes. Key strategies. Infant young child feeding, IYCF, food nutrition security, immunization, institutional delivery, watershed, deworming, OROS, zinc, food fortification, dietary diversification, adolescent nutrition, maternal health nutrition, early childhood development care education, ECD, CCE. Also, the Midday Meal Scheme, now PM Piyoshan, launched 1995, provides healthy food, nutritional education, motivates school attendance. New Focus also monitors nutritional levels. Objectives: improve nutrition, GovTated schools, encourage poor kids to attend, nutritional support in drought disaster areas. Anemia is a major issue. The National Iron Plus Initiative, NIPI, expanded the old NAACP from 1970. Launched 2013, includes adolescents, pregnant lactating women, reproductive age women. Under RMNCH plus A strategy, AIM, provide iron and folic acid supplementation with regular deworming. Let's detail the iron folic acid dosages for mastery. 6 months, 5 years. 20 milligram iron, 100 gram folic acid biweekly, 5-10 years. 45 milligram iron, 400 gram folic acid weekly. 10-19 years adolescent, 100 milligram iron, 500 gram folic acid weekly. Women reproductive age, 100 milligram iron, 500 gram folic acid weekly. Pregnant women, 100 milligram iron, 500 gram folic acid daily for 100 days. Start after first trimester. Nursing mother, 100 milligram iron, 500 gram folic acid daily for 6 months. Women using IUD, 100 milligram iron, 500 gram folic acid daily for 100 days. The weekly iron and folic acid supplementation, WISS, specifically targets adolescent anemia and out of school. Includes screening, referral, counseling, supervised deworming twice yearly. The National Iodine Deficiency Disorder Control Program focuses on iodized salt use, monitoring surveillance, training, mass communication, objectives, surveys, supply iodized salt, reassessment, checking, saltering iodine, health education, and the National Prophylaxis Program against nutritional blindness due to vitamin A deficiency, VAD, major cause of preventable blindness, 5 years. Objectives: prevent, treat BAD, increase VIT-A-rich food consumption, awareness, prophylactic dosing, 9 megadoses, 9 months to 5 years, 1 lakh IU, 6-12 meters, then 2 lakh IU every 6 months till 5 years. Treatment for xerophthalmia. Also doses for measles cases, severe malnutrition.
Finally, a major focus on non-communicable diseases and cancer. Growing burdens globally. India's strategy.
Yes, a big shift. The National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke, NPCDCS, addresses these. AIM: control modifiable risk factors, unhealthy diet, sedentary life, alcohol, tobacco. Early diagnosis management, promote healthy lifestyle. Objective strategies, educate on lifestyle changes, early diagnosis management, rehab care, capacity building, implemented via NCD CELS clinics at national, state, and district levels. 2 components, cancer and NCDs, diabetes, CV diseases, stroke. Nodal agency for training, National Institute of Health and Family Welfare. 12, focusing on sight. Drugs used in ocular disorders.
Our eyes are incredibly complex, delicate organs. Treating their disorders must be equally specialized. Let's delve into ocular pharmacology. It seems like a field with unique challenges just getting drugs to the eye.
It is highly specialized. The eye suffers a wide range of disorders: refractive errors, near farsightedness, glaucoma, cataract, age-related macular degeneration, AMD, and many inflammatory issues, uveitis, blepharitis, conjunctivitis, keratitis, and ophthalmitis. Each needs precise treatment.
And it's tricky getting drugs in effectively, isn't it? All those protective barriers.
You're absolutely right. Ocular drug delivery is challenging. Systemic drugs face barriers: blood aqueous, blood retinal, blood vitreous barriers. The topical route, eye drops, is common, but bioavailability is limited by physical biochemical barriers, corneal structure, limited cul-de-sac volume, and rapid tear drainage, washing the drug away.
So what are the strategies to overcome those hurdles, get the drug where it needs to go?
Several clever strategies. Using carriers that increase viscosity, gels, polymers, to prolong contact time, or carriers that bind to the ocular surface. Matching drug pH and polarity to tissue layers helps penetration. To increase duration. Advanced formulations like gels, ointments, lanolin petroleum base. Also drug-impregnated contact lenses, implants, solid inserts like pilocarpine certs for constant glaucoma drug delivery.
What about getting drugs deeper into the eye?
For more prompt or posterior delivery, we use injections. subconjunctival, under conjunctiva, retrobulbar, behind eye, and critically intraocular or intravitreal, directly into the eye. These bypass many barriers. Novel methods are emerging too. Transcaral delivery across the white of the eye, drug encapsulation in nanoparticles, even gene therapy are being explored.
Fascinating innovation. Let's explore the different classes of drugs used specifically for the eyes. What are the main categories?
We can categorize them like this. 1. Antimicrobial agents. For eye infections, A. Antibacterial. Against staph, strep, hemophilus, chlamydia, gonococcus, drugs, fluoroquinolones, sulfonamides, aminoglycosides, bacitracin. For size, conjunctivitis, keratitis, endophthalmitis, etc. B. Antiviral. Against herpes simplex, herpes zoster, CMV. For viral keratitis, retinitis, herpes zoster ophthalmicus. Drugs, acyclovir, ganciclovir, foscarnet, idoxuridine, trifluridine. C. Antifungal. Less common infections, keratitis, and endophthalmitis. Drugs, topical F, Ptericin B, natamycin, fluconazole, miconazole, challenging to treat. D, antiprotozoal for parasites like toxoplasma, acanthamoeba, managed with combo topical systemic drugs, e.g. imidazolines, corticosteroids, antibiotics for acanthamoeba, NSAIDs, topical use post-op, pain inflammation during surgery, prevent meiosis pupil constriction, drops like diclofenac, ketorolac, flurbiprofen, nepofenac. B. Glucocorticoids, steroids. Powerful. Treat uveitis, post-op inflammation, conjunctivitis, keratitis, allergies, burns. Topical. Dexamethasone, prednisolone, etc. Oral parenteral for deeper inflammation. Posterior uveitis, optic neuritis. 3. Antihistaminic drugs and mast cell stabilizers. For allergic vernal conjunctivitis. Antihistamines, antizoline, azelastine, etc. block histamine. Mast cell stabilizers, cromolyn, sodium, ketotifen, etc. prevent histamine release. 4. Mudriatics and miotics control pupil size. Amutdiuretics dilate pupil. Antimuscarinics, atropine long-acting cyclopentolate, tropicamide shorter-acting, cause dilation, mydriasis, and paralysis of focus, cycloplegia. Adrenergic agonists, phenylephrine, cause mydriasis without cycloplegia. Uses, refractive testing, fundoscopy, pain relief in iridocyclitis, breaking adhesions. E. Miotics constrict pupil, muscarinic agonists, pilocarpine, anticholinesterase, alternated with mydriatics. 5. Immunosuppressive agents and antimitotic agents. Uses. Chronic dry eye, preventing scarring after glaucoma surgery. Systemic diseases affecting eye, Wegener's, Besteds. Drugs. Fluorosil, minomycin, lifitrast, anti-VEGF agents. Huge breakthrough for wet age-related macular degeneration, AMD. VEGF drives abnormal blood vessel growth, neovascularization. Drugs like bevacizumab, ranibizumab, aflibercept injected into the eye prevent this, preserving vision. 6. Local anesthetics, topical drops, infiltration, or retrobulbar block. For foreign body removal, laser surgery prep, tonometry. Drugs, lignocaine, tetracaine, bupivacaine. 7. Diagnostic agents, specialized dyes. Fluorescein detects corneal conjunctival defects, checks tear duct patency. Rose bengal stains devitalized tissues. Indocyanine green for retinal angiography. 8. Miscellaneous agents. Artificial tears lubricants for dry eyes, e.g. carboxymethylcellulose, provide comfort protection.
A truly comprehensive toolkit for treating eye conditions. 13. Strategic drug use. Essential medicines and fixed-dose combinations. When we think about making drugs accessible and effective for everyone, globally and locally, two concepts seem really important: essential medicines and fixed-dose combinations. Sounds like they're about practical, ethical drug availability, especially where resources are tight.
That's absolutely right. The concept of essential medicines is crucial for global health equity and efficient healthcare. The WHO defines them as medicines satisfying priority healthcare needs that should be available always, in adequate amounts, appropriate forms, and affordably. It underscores accessibility, availability, and affordability key for universal health coverage. The history started with the first WHO model list in 1977. It's been modified since. The latest, 22nd, 2021, has 479 medicines. Countries also make their own National Essential Medicine List, EML, based on local diseases, updated regularly. India's NLM 2022 has 384 drugs. These lists guide procurement, prescribing, policy.
What gets a drug onto this vital list? Must be a rigorous process.
Very rigorous, balancing science, public health, economics. Key characteristics for selection: assured quality and suitable dosage forms, proven quality, stable, appropriate forms, sufficient safety and efficacy data, robust evidence needed, comparable cost effectiveness, good value within its class considering total treatment cost, favorable pharmacokinetic stability, practical properties, stable storage, fixed dose combinations, FDCs. Included only if clear advantage in efficacy, safety, or reducing resistance, like for TB, malaria. Not just for convenience. Dynamic selection. Process is ongoing, adapts to changing needs, new evidence.
And speaking of fixed dose combinations, FDCs, what are they and why are they seen as so beneficial despite the complexities?
Fixed drug combinations, FDCs, combine more than one active drug in a fixed ratio in a single dosage form, like one pill. Critical requirement: the drugs must have similar or matching pharmacokinetic profiles, half-life, distribution, peak concentration, to work predictably together.
Seems like clear advantages, especially for adherence in chronic diseases.
Significant benefits, yes. Improved patient compliance adherence. Huge benefit. Fewer pills simplifies regimens, boosting adherence, better outcomes. Augmented drug effects, synergy. Combined effect greater than sum of parts. E.g., amoxicillin plus clavulanic acid. Clavulanate protects amoxicillin broadened spectrum. Oral contraceptives, levodopa, carbidopa. Carbidopa boosts levodopa at the brain. Reduced drug resistance. Crucial for TB, HIV, malaria. Combining drugs with different mechanisms makes resistance development much harder than with monotherapy. Reduced side effects, sometimes. Lower doses of each component might reduce individual side effects, or one drug might offset another side effect.
But combining drugs isn't always simple. What precautions are needed to ensure FDCs are truly beneficial and safe? Potential pitfalls.
Right, judiciousness is key. Important precautions. Enhanced effects without added side effects. Combination should boost therapy, not just add up side effects. Can be hard to tell which drug causes an ADR and an FDC. Judicious and rational use. Only combine required medicines with complementary actions. Avoid unnecessary drug exposure and cost. Patient-specific factors. Consider a patient's kidney liver function for each ingredient's metabolism excretion. Matching pharmacokinetics. Profiles must match closely for predictable, optimal effects throughout the dosing interval. Good examples of approved FDCs on India's NLM show rational combination. Cotrimoxazole, trimethoprim plus sulfamethoxazole, sulfadoxine plus pyrimethamine, malaria, ethanyl-lestradiol plus levonorgestrel, contraceptives, carbidopa plus levodopa, Parkinson's, lignocaine plus adrenaline, local anesthetic, aluminium hydroxide plus magnesium hydroxide, antacids, oral rehydration salts, ORS, vital combo for diarrhea. These offer genuine advantages when rationally designed and used. Pharmacoeconomics of healing. Pharmacoeconomics.
Okay, beyond the pure science, there's this vital economic dimension to healthcare. Finite resources, many treatment options. How do we make the best choices for both health outcomes and financial sustainability? This is where pharmacoeconomics comes in, right? Sounds crucial for optimizing systems.
Indeed. Pharmacoeconomics systematically identifies, measures, and compares the costs and outcomes of pharmaceutical products and services. Hugely important, especially in developing countries like India where resources are limited. Every rupee spent needs to deliver maximum health benefit and value. It's about making sure effective treatments are also affordable and sustainable.
So how do you actually do this comparison? What are the specific methods pharmacoeconomists use to evaluate different treatments?
There are 4 primary methods, each giving different insights. A. Cost minimization analysis, CMA. A. Cost minimization analysis, CMA. Simplest method finds the least expensive option. Key condition. Treatments must be equivalent in safety and efficacy. If outcomes are identical, lowest cost wins. Results purely monetary. B. Cost effectiveness analysis, CEA. B. Cost effectiveness analysis, CEA. Most popular. Compares relative costs and outcomes measured in natural units. Units like years of life prolonged, disease-free days, cases cured. Assessed by mortality rate, treatment duration, etc. Results usually as a ratio. Average cost-effectiveness ratio, or more commonly, incremental cost-effectiveness ratio, ICER. That's the extra cost for an extra unit of effect, e.g. cost per year of life gained. Helps decide if the extra benefit is worth the extra cost. C. Cost-benefit analysis, CPA. C. Cost-benefit analysis, CPA. Compares costs and outcomes, but uniquely, all costs and outcomes are expressed in monetary units. C. Cost-benefit analysis, CBA. Benefits like improve health or save lives get assigned a monetary value, e.g. productivity loss avoided. Results as net benefit or benefit cost ratio. Limitation, big one. Assigning monetary value to health life is ethically challenging, often unreliable, limited use in healthcare. D. Cost utility analysis, CUA. D. Cost utility analysis, CUA. Outcome measured as quality of life, or QALY's quality adjusted life years. D. Cost utility analysis, CUA. QALY combines quantity years lived and quality of that life. 1 QALY equal 1 year perfect health. Year with reduced quality, 1 QALY. QAY, D cost utility analysis CUA, ICER expressed as incremental cost per QAY gained, use case, comparing treatments with similar survival but different quality of life impacts, for example, cancer drugs with harsh side effects, allows nuanced value assessment.
So why is this analysis so important overall?
It provides a systematic way to compare costs and consequences of different drug treatments. Goal: maximize therapeutic outcomes using limited resources. Practically, hospitals use these methods for their essential medicine formularies. It also influences drug pricing decisions and reimbursement policies. It's about getting the most health for the resources we have. XV, the gold standard. Good clinical practice, GCP.
Finally, let's talk about how drugs are rigorously proven safe and effective before they even reach patients. The bedrock of drug development, ensuring trust and reliability. Good clinical practice. What is GCP and why is it so fundamental?
GCP is indeed the gold standard, non-negotiable. It's a comprehensive set of ethical and scientific quality standards from the International Conference on Harmonization, ICH. Its purpose: rigorous guidelines for designing, conducting, monitoring, auditing, analyzing, reporting clinical trials involving human subjects.
What does following GCP ensure?
Critically, it safeguards the rights, safety, confidentiality, well-being of trial participants. That's paramount. It also streamlines studies, standardizes them globally, and it maintains the credibility and integrity of trial data, ensuring results are reliable for regulators and scientists. Key stakeholders: sponsor, investigator, participant, regulatory authority, ethics committee, IRB.
What are the core principles guiding these practices? The non-negotiables for ethical sound trials.
The principles are fundamental, universally applied. Ethical conduct. Trials must follow ethical principles. Declaration of Helsinki. Participant well-being trumps science society interests. Participant rights, safety, well-being must be ensured above all else. Voluntary informed consent. Participation entirely voluntary, based on full understanding of risks benefits. Can withdraw anytime. IRB ethics committee review. Protocol, consent forms, etc. must be reviewed, approved by independent committee before research starts. Ensures ethical oversight, scientific basis, and qualified personnel. Trials based on solid science conducted by qualified people. Clear and feasible protocols. Concise, clear, feasible protocols generating reliable results. Well-defined roles and documentation. Roles, responsibilities clearly defined, documented for accountability. Quality control. Essential throughout. Investigational products manufactured, stored, handled to specifications. In India, the Good Clinical Practices Guidelines are formulated by CDSU, aligned with ICH GCP, adopted by the Drugs Technical Advisory Board, paramount for safety well-being of human subjects in Indian trials, ensuring alignment with global standards. This system underpins our trust in tested medicines. Outro.
Wow, what an incredible journey we've just completed. We've really plunged into the incredible breadth and depth of pharmacology, from the tiniest molecular interactions
Right down to the basics.
to vast national health initiatives impacting millions.
Indeed. We've seen how pharmacokinetics and pharmacodynamics lay that foundational groundwork, how evidence-based medicine and TDM ensure personalized, effective, safe care, the ingenious ways drugs are formulated and delivered. We also explored the critical vigilance needed for drug safety via pharmacovigilance, the urgent interventions in shock and MI, and how we manage common things like cough.
And we didn't stop there. We delved into uterine drugs, the constant battle against antimicrobial resistance, even hidden dangers in food and environment. Plus the incredible scale of India's national health programs, the science behind eye treatments.
And finally, the crucial role of pharmacoeconomics and the ethical backbone of good clinical practice in bringing safe, effective treatments to you.
This deep dive has truly given us a masterclass. It highlights how every aspect of pharmacology touches our lives, often in ways we don't even realize.
It really does. It's a dynamic field dedicated to improving health, from the individual patient to entire populations. The precision and foresight involved are just incredible when you dig into it.
So after this comprehensive exploration, what stands out to you from today's deep dive? What concept are you curious to explore further in your own learning journey? The more we understand this vital science, the better equipped we are to navigate the complex world of medicine and health and grasp the principles elite professionals rely on.
Keep asking those questions. Keep digging deeper into the why and how, because knowledge, especially in health, well, it's truly power.
Join us next time for another deep dive where we'll unpack even more fascinating insights.